Again, thank you very much for joining us this morning for this presentation, part of Kirby Center's 2022 series of online health, wellness, information, and entertainment presentations. Did you know that all Albertans over the age of 18 should have a personal directive? If you were unwell and unable to speak for yourself, do those who are close to you know your wishes for healthcare and your personal decisions? This morning's topic is one that people are often reluctant to face, let alone talk about. However, while advanced care planning is important at all times, COVID-19 has brought awareness of the importance of knowing your own and your loved ones' wishes and values regarding their health care to the forefront. Today, we're fortunate to have Alexandra Kushliak join us as we recognize Advanced Care Planning Day this week to help start the conversation. Alexandra is an education consultant with Advanced Care Planning and Goals of Care, Calgary Zone, Alberta Health Services. She received her BA Psych from the University of Manitoba in 1979 and her social work degree in 1984. Over the past 35 years, she has worked as a social worker in the medical field, including acute care, rehab settings, and supportive living. She has brought her social work expertise in running educational groups for stroke units and the Cancer Society of Winnipeg. In coming to Calgary 22 years ago, she has worked on several transition units, long-term care, hospice, and supportive living. She is a strong advocate for clients and brings her passion for clients' rights to advanced care planning. She has been part of this Calgary Advanced Care Planning Goals of Care team for 7 years. Alexandra enjoys teaching regularly offered courses as well as going out to the public to spread the word that everyone over the age of 18 should have a personal directive. Alexandra, this is the week that we celebrate or recognized advanced care planning on April 16th. Why is it so important that we have a personal directive? And what should we know about being prepared with an advanced care plan?
Thank you, Colleen. And those are the topics that we're going to be talking about in terms of why it's so important, like you said, to have a personal directive. I'm going to walk you through those steps in terms of what to put in your personal directive. And also I'm going to talk a lot about the goals of care and how that impacts you as an individual and maybe as a relative. So I welcome everyone and thanks for joining us this morning. I hope you're nice and warm and have a cup of coffee through it. Colleen did a great introduction for myself, for me in terms of what my background is. And just a reminder that not only have I used personal directives and goals of care in my professional life, but it is really important for me in my personal life in terms of I have my own personal directive. I'm the agent for my mother's personal directive, which is enacted, and she's in long-term care. So this is not just a topic that I teach, it's a topic that I live on a daily basis. So again, thank you. You could have chose to do anything else this morning, but you chose to join us for this important topic. So I'm really thankful that you did. And I just want to acknowledge that we're all a little bit stressed nowadays, some more than others. I have family back in Ukraine, so it is kind of a stressful time with COVID, with things not being very stable. But I do want to reassure you that you don't need to take notes during this presentation, that I will tell you where you can get all the information at the end of the presentation. So I don't want you to be stressed during the presentation thinking you have to memorize the information. I do want to acknowledge, like Colleen said, COVID has really brought a difference to how we're thinking about healthcare, how we think about ourselves. And what it's really brought to the forefront is that COVID is like any other medical emergency. We need to be prepared for it. We need to be informed. What does it mean for me? We need to know our options. We need to inform our loved ones what we want. And we need to know what it means for us, for our own medical condition. And that's for any other medical emergency. And that's why this topic was brought to the forefront because of COVID. And I do want to do a reminder is that part of how we prepare for COVID is to make sure we're as protected as we can. And we know that vaccines work really well. So I encourage everybody to make sure that they have their booster, because it really, especially right now, it really seems to be making a difference. So like I said, I'm going to cover this morning what advanced care planning is, what it is, why, how we should do it, what is that personal directive, and what do we put into it. And then I'm going to show you some videos around goals of care, some examples, and really get down into the nitty-gritty in terms of what the goals of care system actually is. And then where we all carry that information is in the green sleeve, and we're going to go through that. So I want to start the presentation with a video. This is Dr. Charlie Cork. He's actually from Australia, but he does a really good job of saying why we should be prepared, why we should think about these things, why we should have an advanced care plan. So I'm going to just let Charlie do the talking, and then we'll discuss it.
About 80% of people at the end of their life are in a position where they can't make their own decisions. I'm an Associate Professor Charlie Cork, and I'm a specialist in intensive care medicine. Some people will say that my family know what to do, or my doctor will know what to do, and unfortunately they're wrong. When a family's got an advanced care plan and knows what their relative wants, it's enormously easier for the family, because they haven't got all the responsibility of making these, what they see as impossible decisions. And it makes it ever so much easier for the doctors, because doctors are trying to do the right thing. They just need to know what it is. I think advanced care planning, in a nutshell, is three important things. It's about thinking about it, and just thinking about it starts the process happening. Talking about it to your family, talking about it to your doctor. The third thing is picking a great decision maker, because 80% of us right at the end will not be able to make our decisions. Just at the end of life, the way the process goes, you're not able to make decisions, and decisions need to be made. And a great decision maker is able to talk to the family, talk to the doctors, make a decision, make the right decision for you, and to feel comfortable about it. And it makes the whole process so straightforward, so controlled, and so sensible. And that's really, really good.
So if you're interested in more talks by Dr. Charlie Cork, you can Google him. And all kinds of interesting videos come. He's really in the forefront in advanced care planning in Australia. So I just want to go through what is advanced care planning. So it is thinking about and sharing your wishes for healthcare with people close to you. So around the kitchen table when you're having dinner with your family or talking with them, have you talked to people about what your wishes are for healthcare? The second one is choosing someone to make healthcare decisions for you. Sorry, if you become unable. And in the province of Alberta, we call that person your agent. In fact, without a legal document, someone else cannot make decisions for you in Alberta without a legal document. So I think people always think, oh, my husband or my wife can make decisions, but we still need a legal document to appoint your husband or your wife. And like this says, number 3 is writing this information down in a personal directive is where it makes it legal. In fact, we're really lucky in Alberta. We actually have a Personal Directive Act, which outlines the responsibilities of the agent. It outlines the responsibilities of healthcare providers. So it's a really great law and document. I've got this little man down on the bottom of the screen, and you're kind of wondering why they're there. Well, only 2 out of 10 people actually understand what advanced care planning is. And that's why I'm so thrilled that you've joined us today, because it's really not a known concept, and especially in terms of the need for the personal directive. So you're not alone if this topic is new to you. In terms of in Canada, 93% of us actually think it's important to discuss with family and friends our healthcare wishes, but only 59% of us actually go through with it and do it. 77% of us think it's great to discuss it with a healthcare provider or your healthcare team, but only 7% of us do it. 66% of us think it's really important to discuss with a lawyer, but only 12% do it. So we're thinking about it. We think it's a really great idea. We think we should discuss it with other people, but we're really not great on the follow through. And that's the main thing I want to say today, is that we really need for you to follow through on some of these concepts. And why don't we have that follow through? Why are some of us people thinking that we don't need it? Well, my dad was one of those. He would say, well, I have a will. Why do I need that personal directive? You know, I'll just die, and what's with the fancy personal directive? Well, if he died in the 1950s, he would have been right? Most of us around those times died suddenly, not a lot of decisions to be made. So your will would have been fine. But unfortunately, or fortunately, nowadays, 85% of us will die in one of these trajectories. And if you look at the graphs, whether it's terminal illness, whether it's organ failure or frailty, it's over time. And over that period of time, decisions have to be made. And unfortunately, my father landed in one of those trajectories. He had a stroke. And over the 2 years before he died, there was decisions to be made. Where is he going to get treated? What kind of medication is he going to have? Who's going to make decisions for him? So you can see how important it is to have a personal directive, so you know what somebody wants. Another way of looking at it is that in long-term care, we have a lot of people maybe in long-term care for 10 years. So if you think in long-term care, the majority of people can't tell us what they want, and if you haven't filled out a personal directive, and if you haven't talked to your family about what kind of healthcare you want, for over 10 years, the question is, what kind of healthcare did grandma want? You know, who's going to make the decisions for grandma? So, or your father or your mother. So it's very important that we think about these things and actually follow through on them. So this is the 5 steps in advanced care planning that we teach at Alberta Health Services. So the first one is thinking about your wishes and values. So give it some thought. What's really important to you? Think of it in terms of, you know, for some people, being able to walk in the mountains is really important, and they wouldn't think their life had any value if they wouldn't be able to do that. For other people, it's, you know, making sure if I can eat ice cream in front of them and watch a football game, I'm a happy camper. So everybody's wishes and values are a little bit different. Number 2 is learn about your own health. If you don't know what your health is going to be in a month from now, in 2 months from now, in a year from now, it's really hard to plan, right? So if you had that conversation with your doctor or physician about what your health may look like down the line, because then you can plan for that, right? That's a discussion. And unfortunately, most of the public have a really poor idea of their own health. So it's really important to have those discussions. Number 3 is choose someone to make decisions and speak on your behalf. So you really have to stop and take a little thought about who are you picking. I've chosen my husband and my daughter to make decisions together because I think they make a great team and they'll be able to make decisions in a emergency, and they'll be able to communicate well together with them. So sometimes you may not want to choose a family member, and the Personal Directive Act is great. You don't have to choose a family member. In fact, your agent doesn't even necessarily have to live in the same city you are, same province or country, as long as we can reach them. And a lot of times people are communicating like today by Zoom. So they see each other on a regular basis. They know what their health condition is like. And sometimes that person even goes to medical appointments with them. And that's probably the person you want to choose to be your agent, right? Because they should know your situation. They should know you and make those decisions as if it was you. Number 4, if you're going to ignore everything I say today, is probably the most important one. Communicate your wishes and values about healthcare to your family, to your friends. So if an emergency happens, whether it be a motor vehicle accident, whether it be COVID, your family and your friends know what you would want, right? They would be able to make decisions on your behalf and knowing that that would be what you wanted. But where we put this process down to make it legal is in that personal directive. So until we put it in a legal document, then it really outlines who's going to make that decisions. And then we have to follow what you've put in the personal directive if you put it in a legal document. So it's really sort of solidifying all of those of your wishes and who's your agents by putting it in that legal document. Now, remember I said that my dad said, oh, he had a will and he thought he was good to go. So people confuse all the documents and say, well, why do I need this if I've got another one? Well, in the province of Alberta, you actually need 3 documents. So you need a will, and that only gets looked at after you die. So nothing to do with healthcare while you're alive, nothing to do with personal decisions. You need an enduring power of attorney, which appoints someone to manage your money and your property if you cannot, right? So again, nothing to do with healthcare, nothing to do with personal decisions. The personal directive is the only document that appoints someone to make decisions around healthcare and personal decisions. So it's really great to have all 3. You don't need to have the same person stated in each document. You can have 3 different people or the same person. It's entirely up to you. What I do say is these documents are kind of insurance, right? I have an insurance on my house. I'm kind of hoping it doesn't burn, but I still have insurance. I'm not planning for it to burn. I got insurance for my car. I don't want to get into a motor vehicle accident, but if I do, I've got insurance. So these documents are kind of like that. We can't make you do these documents, but they're insurance. So if something happens, you've got somebody to make decisions for you. The same thing is that if you die without a will, then it needs to go to court. If you don't have an enduring power of attorney, then other decisions have to be made, maybe a court. So things becomes really complicated if you don't have those documents. So I just want a reminder that the personal directive is that legal document that allows you to appoint someone for healthcare and personal, nothing to do with money, right? And the personal directive is the only document that kind of lets us know who you are. Because remember, the other 2 are kind of about your property and about your money, but it doesn't really let us know who you are. It doesn't let us know what's important to you. It doesn't let us know what your values and your wishes are. So that's why the personal directive is really a different one. But remember I said it's kind of like insurance. So the personal directive kind of just sits there until you lose capacity. And then there's very specific paperwork that's done by your physician and someone you've named in your personal directive to assess your capacity. They together would determine when that personal directive would be enacted or brought into play. So a lot of people say, well, I don't want to do a personal directive because I don't want somebody else to make decisions for me. Well, it doesn't get looked at until you lose capacity. So let's say you have a personal directive, and I hope some people out there have a personal directive. So you can write a personal directive with or without a lawyer, but you should keep the original in a safe place. So if you have one, make sure the original is in a safe place. But the next step is to make sure you give copies to your agent, to your healthcare providers, to your family. This should not be a secret. And why do we want to give copies out? Why do we want everybody to know? Because if something happens, then we all know who your agent is. We all know what your values and wishes are. So we're all going to be there to support you and follow through on your wishes. So a lot of people think, oh, I should, it's a secret, I should keep it a secret. No, this is one of these documents you actually want to have everybody know about. So the Personal Directive Act has made it really easy for us to do a personal directive. There is no standard format. You can handwrite one. You can use the form from the Office of the Public Guardian. You can use the form from the Dying with Dignity website. As long as it's signed, dated, and witnessed, it makes it a legal document. So there's all kinds of different ways you can do it. I do want you to check your documents, though. If you've done a will in the past 5 to 10 years, most lawyers would have done all 3 documents at the same time. So they would have done your will, the enduring power of attorney, and a personal directive. But I don't know about you, but when I went to the lawyer, you told them what you wanted, they gave you a bunch of papers and you signed them all, and you weren't too sure what you were signing, but you hoped everything was in there. So check your documents, because you would have actually 3 different documents. You would have your will, your enduring power of attorney, and your personal directive. I certainly don't want you to redo your personal directive if you've ever done one with a lawyer. Specifically, if you've done one with a lawyer, it does have another layer attached to it, because the lawyer will determine what your capacity was at the time of signing. So there's an affidavit the lawyer includes saying, yes, this person was able to sign and understand this document. So I want to go through a little bit about what you put in a personal directive and what to look for. So let's say you've written a personal directive, find it, dig it up, and look at it to see if it still says what you want it to say. Does it still have the agent that you want? Is there enough instruction in it that your family, the agent, can make decisions on your behalf? Does it look different than somebody else's? Because remember, the personal directive should be very unique to you because everybody's wishes are different. And what's important to us is different. So the first important part of the personal directive is the revocation of previous personal directives. Personal directives aren't like wills, right? It's not the last one dated. If you don't revoke any previous personal directives, you can actually have more than one at play at the same time. And unfortunately, I was in that situation where I was working with a client, 2 personal directives were produced with 2 different agents, and the latest one did not say, I revoke all previous personal directives on it, which meant both of them were at play at the same time. So it's very important if you make a new personal directive that you include the statement, I revoke all previous personal directives. Because if you're handwriting it or doing it on your own, most of the forms will have that statement in it, but that's really important to check. Now, in terms of how do we pick an agent and how do we write it down in the personal directive, we really want to make sure that you pick more than one agent because that is really important. But how you write it down does make a difference. So I have people who say, you know what, I have 5 grown children, adult children, and I want to name all of them in my personal directive because they don't want to offend anyone. And they go down the line and name all their children. And that's why I have all these little people holding hands. The issue with that is if you put "and" between all their names, then they all have to make a decision together. The Personal Directive Act does give us some direction. They say they do need to appoint a spokesperson and the majority rules. But I don't know about you, but if that many people are trying to make a decision in my family, it would kind of be hell on wheels. So if that situation works for you, because remember I said every family is kind of unique, then you can go ahead and do that. But just be aware that, it's kind of cumbersome in terms of having that many people make a decision together. Another option is Mary or Bob, and that means either one of them. So if Mary shows up to the hospital first, she's making decisions. Let's say if she needs to go out of town, then Bob can step in and make decisions, and they can swap in and out. So that could work if you've got 2 adult children who work well together or on the same page, that could work well. But again, you have to assess whether that's going to work for you in your family. What most lawyers suggest and what the document from the Office of the Public Guardian suggests is that you pick a primary, and we have Mary Smith here picked, and then you can pick as many alternates if you would like. So here we have Bob. So if something happens to Bob, then, if something happens to Mary, then Bob would make the decisions. If something happened to Bob, then it would go down the line. And that's why we have our people standing in a row. So sometimes people just pick one agent and there is a risk to that. I had a lady, did the right thing, did her personal directive, picked her adult daughter, who was a great choice, knew her well, was going to make decisions for her well, but unfortunately the adult daughter died before she did, and then she was left without an agent. So it's like our theme today, life happens and you need to be prepared and you never know what's going to happen. So what do I write in the personal directive? Remember I said this is a really unique document. And it is a document that is going to direct your health care if you cannot tell us what you want. So how can I do that? What do I write in there that's going to direct that? The best way to do it is writing quality of life statements. What's the most important thing in your life? Remember I talked about, the guy that likes to climb the mountains? Well, that would be in his personal directive. That's maybe really important to me. But if for me, maybe watching TV, my favorite programs, maybe that's the most important thing for me, or being with my family. So what does quality of life mean to you? Because that again is different for everyone. What could you not live without? So people said, if I can't talk to my family, if I can't, eat on my own, if I can't be independent, then that would be really difficult for me. And what does poor quality of life mean to you? And are there any situations where you would not want life prolonged? We've all seen TV programs, and maybe you've been through something yourself that you're very sure of. For myself, I've got in my personal directive, if I lose capacity and can't recognize my family for, a period of time, then I would not want my life prolonged. And that means all kinds of things. And I've got more specific things on my personal directive that under certain situations, I would not want to have tube feeds, but that's personal to me, right? So then you need to really kind of dig deep and figure out what's important to you. You can be more specific in your personal directive. Let's say you already have a diagnosis of, let's say, cancer or kidney disease. You can say in your personal directive, if I, lack capacity or unable to make decisions on my own anymore, then I wouldn't want to continue with my cancer treatments, or I wouldn't want to continue with my kidney treatments, or I would. Because again, it's your personal directive. It's very different for you. We have on our Conversations Matter website a video of Deb Cook, who talks about her mother, who put her end of life wishes in her personal directive. And the family really appreciated that. And in that personal directive, she put that she wants to be surrounded by family. She wanted to make sure that music was played, that she could look out the window. And the family was able to fulfill that for her. So it was a gift for the family because they knew what to do. And it was a gift for her because she knew her end of life wishes were granted. The other part of that is for my mother's personal directive. She's got in there, she doesn't want CPR or chest compressions. So she doesn't want all the bells and whistles of intensive care unit. So again, everybody's personal directive is a little bit different, and it depends on what your wishes are. So remember I said that what makes the personal directive legal is that it's signed, dated, and witnessed it. So who can witness it? Well, again, the Personal Directive Act has made it really easy for us. If you're not going to a lawyer, then your witness can be anybody who's 18 or older. They should initial where you've initialed. They need to watch you sign and date it, and they need to sign and date it in front of you. So I don't know how many times as a professional I was called in to witness someone and they had already signed it, and then I would have to have them redo it. So it can be a neighbor. It doesn't have to be a notary or a lawyer. So if you're doing one on your own, they've made it really easy. I do have lots of people say, that I'm a strong opponent. Can I put medical assistance in dying in my personal directive? Can I put organ donation in my personal directive? Well, if you're handwriting your personal directive, you can say that you would like medical assistance on dying in some circumstances. Unfortunately, right now, we can't follow through on that because you have to have capacity to be able to request medical assistance in dying. So we can't say, and remember, your personal directive doesn't get looked at until after you lose capacity. So it kind of doesn't fit. The laws are changing. So if you go to a lawyer, they wouldn't let you put medical assistance in dying in your personal directive because it's illegal at this point to follow through on somebody's medical assistance in dying after they lose capacity. The laws have changed and they may change again. Right now for medical assistance in dying, if you're assessed and approved and have given a date, you can sign other documents that will have them proceed with the medical assistance in dying if you lose capacity between the time that you've been assessed and the date of the medical assistance in dying. So that's a little bit different than putting it in your personal directive. The other part is organ donation. It's a great place to put it in your personal directive. The issue is about organ donation is that your organs don't belong to you after you die. So it's great that you make sure you go to the registry office and fill out documentation, that you let your family and your friends know that that's important to you. Because a lot of the times when the family is making the decision, it's not that they don't want to, it's that they weren't sure about whether you wanted it or not. So it's really important that if this is something important to you, that again, it's that conversation. It's letting people know what you wanted. If you want more information about medical assistance in dying, Alberta Health Services is really good. They have a website. You can go on it and get all the information you want, or call 811 if that's something you want information about. What we say about advanced care planning is don't wait. That the time will never be just right. I don't know how many people said, oh, I'm waiting for my daughter to come in, then I'll do that personal directive, or I'm waiting for such and such a time, or I'll do it in the spring. So we really know, because life happens, right? Especially with COVID. Who would know that, after a couple of years, we're still dealing with COVID. Things happen that we just don't anticipate. So what I've been talking about is this green bubble, is advanced care planning. So that part everybody can do, right? Everybody over the age of 18 can talk about their values and wishes, what their fears are, can talk to their doctor about their illness and what's going to be coming up, can do a personal directive. The issue becomes is that once you have health issues, once you maybe go into the hospital, if you have some kind of chronic disease process, then the medical department and healthcare providers need a document that lets us know what kind of healthcare you need right this minute. And those are called the goals of care. So most people don't know the goals of care, don't need the goals of care. I don't have a goals of care because if I collapse, EMS is going to come in and do absolutely everything. But if there's some things that we're like, remember my mother, she didn't want CPR. She didn't want certain things. So how do we make sure that the medical people that are coming in to serve her know that? So that's called the goals of care. And those should be consistent with people's values and goals. And so that's why having these conversations, thinking about your values and wishes is so important. So if you need that conversation with your physician around the goals of care, you're prepared, you know what's important to you in your life. So we can determine a goals of care on those conversations. Now, in terms of this next part of the presentation, this is not for you to memorize. You don't need to know all the goals of care. It's just that so that if you do have a conversation with your physician, you're a little bit more prepped, because the goals of care are always determined with you and your physician. It's not something that you can do on your own. So I don't want you to think that you have to memorize all this information or know it. It is always done with a conversation, but it's a little bit of background for you. So if you're having those conversations with your physician, or if you're making decisions for someone else, you're a little bit more prepped. So the goals of care are divided into 3 sections: resuscitative care, medical care, and comfort care. The best way for me to explain the goals of care is to actually show you a video, because goals of care is stuff that we do to you, right? In terms of, or not do to you. And so it's easier explained by a video. So this video was actually done in Calgary a little while back. And all the people are actors. There's a scene in an intensive care unit. There's a scene with somebody getting CPR, but actually the person that's getting CPR is a very large doll. So none of it is real. So, but if these scenes may trigger you, if you've been in intensive care unit before, this video is about 9 minutes. So you can look away and then come back in 9 minutes. Don't sign off just in terms of it may be harder to sign back on again. I just wanted to warn you about the video ahead of time.
Goals of care are designations used by your healthcare providers to describe the general aims of your healthcare and the preferred location of that care. Decisions about goals of care usually arise over time through conversations between you, your family, or loved ones and your healthcare team. The process of thinking about, talking about, and documenting your wishes for healthcare is called advanced care planning. In a medical emergency, your goals of care designation guides your healthcare team to provide timely care that is both medically appropriate and reflects your personal values and wishes. There are 3 general approaches to care or goals of care: resuscitative care, medical care, and comfort care. In resuscitative care, the main goal of care is to prolong life by curing or controlling your health condition. This means that doctors and nurses could use intensive medical and surgical interventions, if these are needed, to keep you alive and could be expected to cure or control your illness.
Code blue, Unit 182.
If your heart stops, they may perform cardiopulmonary resuscitation or CPR. You may have seen resuscitation or CPR performed on television or in the movies. The person usually recovers easily, but this doesn't tell the whole story. Resuscitation measures like CPR work best in emergency situations where the heart stops suddenly, but the person is otherwise pretty healthy. It's important to know that CPR normally cannot restart the heart or restore life when the heart has stopped as a result of a severe or terminal illness. In CPR, the doctor or nurse repeatedly pushes on the chest with great force and periodically puts air into the lungs. Electric shocks, called defibrillation, may also be used to restart the heart, and some medicines might also be given. If the patient's heart starts to beat again, most patients require a stay in intensive care and a period of rehabilitation before they are well enough to leave hospital, and some people are left with permanent damage from their heart stopping. Resuscitative care can also include using medications and other treatments that are provided in an intensive care unit or ICU. The ICU is a very specialized unit in a hospital with doctors and nurses who are trained in using special equipment and medications to care for very sick people. An intervention that may be used in the ICU to prolong your life is a ventilating machine. These machines are used if you're unable to breathe on your own. This means putting a tube which is attached to a machine down the throat into the windpipe to push air into your lungs. Because this tube can be quite uncomfortable, people are often given medications to keep them very sleepy or sedated. You cannot eat or talk while on this machine. If you have a potentially curable or treatable condition, ICU care might be needed to help you heal. The hope is that you will return to your previous health, but it is important to understand resuscitative care and procedures used with the aim of prolonging life may or may not achieve that aim of restoring your previous health. In medical care, the goal of care is also to prolong life and to cure or control your health condition, but without the use of resuscitative care and the ICU.
Good morning, Mr. and Mrs. Johnson. How are you this morning?
Medical care can be appropriate if your health condition is such that intensive or resuscitative care such as CPR and a breathing tube are unlikely to work. Or your wishes and values about healthcare may be that you would not be accepting of these intensive medical treatments. For example, if they are unlikely to restore you to a state of health that you would want. In the medical approach to care, your doctors and nurses will provide tests and treatments for any treatable problems that may arise. This approach may include surgery and medical treatments such as blood transfusions, kidney dialysis, feeding tubes, antibiotics, and other medicines or fluids given through your veins. Most of these treatments mean going to the hospital.
Of course, you know how much she loves dance. Okay.
Hi,
So of
Pat.
course, she
Good afternoon.
Some people want to receive only the life-prolonging treatments that can be provided in their home or in the care center where they live, even if this limits what treatments are possible. If your goals include a desire to avoid going to the hospital for treatment, talk to your doctor about what treatments may be available and helpful to you in your home or care center. When your health condition or your values and wishes reflect a goal of maximizing comfort and relieving symptoms, this approach is called comfort care. Your doctors and nurses will give you medicines and other medical treatments to help control uncomfortable symptoms such as pain, trouble breathing, or feeling sick to your stomach. The main goal is not to prolong life, it is to maximize your comfort. Resuscitative treatments are not used. Comfort care does not mean that you receive less care. It means the focus of your medical care is on quality of life and reduction of symptoms. People receiving comfort care are usually treated at home, in hospice, or in a long-term care center. However, sometimes hospitalization may be needed to provide optimum comfort.
You know, he feels a lot weaker when he can't keep anything down.
In the hospital, the approach to care will continue to be focused on providing comfort and relieving symptoms. It's helpful to keep in mind your wishes and to know about your own health condition when you are discussing goals of care. Resuscitative care, medical care, and comfort care can be divided into more specific subcategories called goals of care designations. These subcategories provide your healthcare team with important information to help guide medical decisions about your treatment. Talk to your healthcare team about which goals of care designation best reflects your wishes and health circumstances.
So remember, we all don't need a goal of care, right? I don't have one, but if you do need one, then this is what the document looks like. And this is what your physician would fill out with you, and your physician would sign. If you're in long-term care or in supportive living, you might get a nurse practitioner would do it. But it's like a prescription that it needs to be a medical order. It needs to be something that your physician would sign. So like I said, not everybody needs a goals of care. You really need to talk to your doctor to find out if you need one. Remember my mother, she decided that, you know, the CPR wasn't going to be for her. She saw my dad go through some things. She wanted to make sure that she got the care what she wanted. So she went to her doctor to discuss the goals of care, and he filled out the documentation, and she carries it with her now. She's in long-term care, but that's something that she has with her all the time. So it is really, if your health changes, then that may be a discussion with your physician. If you don't think that you would benefit from resuscitative care, then this is the time that you would need to have that discussion around the goals of care. As alluded into the video, it does say the resuscitative care, medical care, and comfort care is broken down into different sections. And I would like to review those sections just so that you really have a good idea if you're talking with your physician, or if you're talking about your own care, or maybe about your spouse's care, or maybe about another relative's care. So resuscitative care is broken into 3 sections, and the best way I can sort of explain it to you is by a little diagram and having the incidences. So R1 is, I have been in a car accident, I'm relatively healthy, and I'm going to get whatever treatment that will make me better. I don't know what the outcome will be, but I want to prolong my life at all costs, right? So this is most of us. We want to get everything we possibly can to fix us. And, you know, we'll make decisions later on in terms of what that means. But like I said, for myself, if I collapse right now, EMS are going to do everything they can. R2 is a little different. I know that chest compressions will not work for me, the chest compressions and giving that CPR, but a breathing machine and intensive care will get me back to my active lifestyle. So this gentleman is going to go into an intensive care unit. He'll get what he needs there, but he won't be getting those chest compressions. R3 is a different category. This lady, she says, I suffer from a fibrillation. A fibrillation is when your heart doesn't beat properly. It can be too slow or too fast. Sometimes I need to go into the intensive care unit to get my heart rhythm back on track. I do not want to receive chest compressions, CPR, or be on a ventilator. That's something that's going to help her breathe, as they will not return me back to the state I value. So for the people that have a fibrillation, what happens is they go in the intensive care unit, they get kind of shocked back to where they were before, and sometimes they do it in one day and you're discharged the same day. So very specific care. Medical care is broken into M1 and M2. And again, that's best way is to talk about it is in terms of examples. So M1, we're no longer going in intensive care unit. We're not getting chest compressions. We're not getting ventilation or being in the intensive care unit. So a good example is I'm willing to go to the hospital for any appropriate medical and surgical treatments to try to fix the fixables. I would like to live as long as possible and maintain my quality of life. CPR, chest compressions, ICU, intensive care unit, and the ventilator will not help me, and if attempted, will not leave me in a state of living that I value. So a good example was my mother. Remember, she was 89. She went to the doctor. They had a discussion, decided on M1. So her high blood pressure was still being treated. She was going to the doctor on a regular basis. She was being treated for her macular degeneration. So things were chugging along. Unfortunately, my mother had a stroke in the mall. I was with her, so that was lucky. She had the green sleeve in the back of her wheelchair, so the EMS knew what kind of care to give her. She didn't go into the intensive care unit. She did not have CPR, but they were able to unblock the blockage in terms of her stroke. So she got back, but because of other reasons, she was brought in, she had to go to long-term care and wasn't living independently after that. So she fits right well next into this category, M2. I want to be treated where I live and not go to the hospital. I want medical treatments that are available where I live to try to fix the fixables. When I go to the hospital, I just get worse and they cannot fix me. So that exactly describes my mother. She's in long-term care right now. She's still being treated for her high blood pressure. She still goes out for treatments for her macular degeneration, but she doesn't want to go back into the hospital because she gets a delirium. It's not a great place for somebody who's 92. But if something happened, like if she fell and broke a hip, they would take her to the hospital, fix her up, and then try to get her back to her long-term care where she's familiar and where they know her to get treated there. So comfort care is a different category. We're no longer focusing on cure or control of illness, but we are really looking at symptom control. So C1 is the focus of my care is to provide comfort and to treat my symptoms using whatever medical treatments that will maximize my quality of life rather than focusing on the length of my life. I may be at this level for months or years. So at C1, you still can have blood transfusions, but why we're giving them so that you feel better. You can still have surgery, maybe to remove a tumor so that you can breathe easier, not necessarily to prolong your life, but to make your life that you have more comfortable. So it's all about the focus in terms of making sure that you're as comfortable as you are, using any means, and nothing is really off the table to treat that. C2 is a really different category. This is when somebody's in their final hours or days of life, and it's really an indication for healthcare providers not to move that person. So we're going to make them as comfortable as possible, whether it's in their home, whether it's in hospice, or whether it's in the hospital. That means that, hours to days before death. So I know we've had some people that have come out of, if you're walking around and have a C2 goals of care, make sure that's changed it because that's not the right category for you. I do want to talk about palliative care because a lot of people are confused about palliative care and think that I could only get palliative care if I'm C1, or if somebody says I should have palliative care, that's not a good sign. Well, palliative care is a philosophy, and you can be R1 and receive palliative care or C1. So if you've been diagnosed with a life-limiting disease, let's say you've been diagnosed with cancer, you're an R1 because we're fighting, we're giving you treatment. You can have palliative care because what that's going to do is to make sure your symptoms are under control, to make sure that you're treated as a whole person. We've actually done studies, and people that are put on palliative care early, let's say early in their diagnosis, no matter what they have, whether it's kidney disease or maybe cancer, they actually live longer and better. So and don't be scared if somebody says, oh, I think we should refer you to palliative care. It actually means that we're trying to give you the best care that we can. So what are your next steps? We've given you information about you doing your personal directive. We've given you information about the goals of care, so you have a general idea about it. but what can you do now? So maybe after this, you think, oh, maybe I should have that discussion with my physician. What do I need to do? So you can prep before you go to the doctors, that we have decision tools that'll decide, is CPR right for me? Is kidney dialysis right for me? So you can go through those sort of decision tools on that. And then you can sort of think about some things. What would you like to know about your illness and what is to be ahead, right? So that you have those questions ready. What is the most important for you to have a good quality of life? Or those answers ready for the physician? What are you afraid of about your illness? It's really important for us as a medical team to know that. Are you afraid of pain? What are the things that are bothering you around your illness? What kind of medical care do you not want? And that's really important. A lot of the times we don't really give people choices, even though there are choices. So it's important that if you've gotten some medical care before and you really don't want it, that you discuss that with your physician so that we know, so that we make sure that the care you get is the care that you want. So what kind of things can you ask your doctor? And the most important is what is this illness going to look like in a month from now, a year from now? Because remember, really hard to plan if you don't know what's coming up. What treatments will help me live the way I want and where I want? Really important, because some treatments may mean that you have to go to the hospital 3 times a week. And is that something that you want to do? Is that something you're prepared to do? Some treatments you may not be able to get at home. And is that something you want to do? And what will those treatments do to your quality of life? And are there any alternatives? I'll share a story with you in terms of my boss, whose mother was going under treatments for breast cancer, and they had put in a shunt. And you don't need to know details about the shunt, but what it meant is that she wasn't able to travel, but they never discussed that with her. She was from England, all her family was from England. And what that meant is she wasn't able to fly back to visit her family. So it's really important that you tell the doctor what your goals are. And if you want to travel, if you want to do certain things, the treatments you're getting, does that fit with that? I'm going to show you a couple of videos these are real people, these aren't actors, that talk about using the goals of care, having those discussions with their physicians, talking about it with their family, and what a difference it meant for them and their families. So I'm going to start this first video, and then I'll explain a little bit about the next video.
Well, I was diagnosed with pulmonary fibrosis in December of 2006, actually. And that was after about 5 months of various testing, the type there's no known cause for, and there's no cure. So it's a terminal disease. And it becomes very stressful when you're dealing with that sort of end-of-life disease. And knowing that there's no cure, it's progressed to the point now where I can do very little work, very little exertion, and I'm wearing oxygen 24 hours a day. Dr. Fell sat down with my wife Moira and I, and we talked about the different levels of care and got a good understanding of, if things progress to the worst, what did I want to see happen? And how did I want the medical team to care for me, and what capacity? And the good thing was that my wife was there, and we were able to discuss it, and she agreed upon it as well. So there come to a time when that decision had to be made. She knew exactly what the decisions were. Advanced care planning is a very difficult thing to do, and over the past number of months, my experience with advanced care planning has improved. My knowledge has improved considerably. My wife and I have a personal directive that was made several years ago. And I view the personal directive a little differently when it is done in that context. It's maybe a broader scope document, where this is a living document, and it engages not only your family members, your medical team and yourself. And so it's a team effort as we kind of go through this process. And it's, you know, I think it's been a good experience for us, and one that I don't regret at all going through and doing and working through with my wife and family. As I say, it's one of those topics that you can easily procrastinate at and say, well, tomorrow is always a better day to talk about that. I think the advice that I would offer to someone that didn't want to get involved would be more to think beyond yourself and think about your family and to think about what value something like this provides.
In that video, you know, it's an older gentleman, and a lot of people think, you know, goals of care and personal directives are just for people that are older. But I want to show this next video. It gives an example in terms of how things can happen to anybody and anytime. And that's why it's really helps to have these conversations and to be prepared.
Lorraine was diagnosed with a rare form of cancer about 2.5 years ago. It took a couple of months to actually identify the fact that it was a cancer, and once diagnosed, we found out it was a cancer where the average life expectancy is approximately 6 months, and the cancer progressed quite quickly. The surgery was a success, but unfortunately at that time they found that more tumors had developed, and then she unfortunately passed away about 4 months after that. So I think one of the challenges of cancer care is that there's a lot of different opinions out there around what success looks like moving forward in your life. I think everyone hopes that you will survive, and I think everyone has a story or two about someone who defied the odds and did survive. And so you'll always have people who will be trying to, in some way, often in a very well-meaning way, insert themselves into the dialogue around how you treat or how you approach treatment in dealing with your disease. And I think it can be very challenging. So when it came to decision-making at the end of her life and whether or not she would be able to make decisions, I think we were very naive and very lucky. We had talked in advance about what we wanted to have happen, but I don't think we fully appreciated how rapidly these things can come on and how it can impact the person's ability to actually make decisions. She was probably until the last week of her life, she was very involved in decision making, maybe the last 2 weeks. But again, I think we were fortunate because I know of other situations with other families where something like that happens much more quickly, and people don't appreciate how much more of a struggle that can be once the person is no longer part of the decision-making process. I think the main benefit of having the green sleeve was actually knowing that you could take that with you under any medical circumstance and know that the goals of care designation would be honored by whoever that you were interacting with from a healthcare perspective. The advice I'd give around advanced care planning is it's never too soon to be talking about it. I think even before something happened to us from a medical perspective, we were talking about it philosophically. I think we all like to think that something like this will never happen to us, but the reality is, unfortunately, it sometimes does. And you're so much better off having had those discussions in advance than having to deal with them with all of the combined stress of what is happening with you medically, plus the family consequences and everything that gets piled upon you. So to have had a rational conversation in advance of that, I think was critical to us being able to deal with things in a very timely and the smoothest possible fashion that it could have been dealt with. I think everyone hopes that you survive a cancer diagnosis, and what we learned from our experience is sometimes hope becomes spending the best time you have with your family and friends during the remaining time you have in your life, or spending the best quality time possible with your family and friends in the remaining time you have left. So the idea of reframing hope was one of the most valuable things I took away from the experience.
So I want to talk a little bit about the green sleeve. It was referred to in the video. They're sort of gut-wrenching videos, but at the same time, they really do show you that something can happen when we're not expecting it, we're not planning for it. And that really helps, especially nowadays with COVID. I'm sure a lot of people didn't think they would get COVID, didn't think they would end up in an intensive care unit. And the simplest way to look at this is that, you know, we're all at risk for a motor vehicle accident. So that it could even be something as mundane as a motor vehicle accident, land us in hospital, and then, you know, somebody has to make decisions for us. So I'd like to talk about the green sleeve, what should be in it, how to use it. So the green sleeve is actually that folder. It doesn't really do anything on its own. It is a vehicle to carry your advanced care planning documents. So what should go in there is a personal directive, a copy of it. You should have the original in a safe spot. Under the Personal Directive Act, all healthcare providers can accept a copy. In terms of what else goes in there is the order form, the GCD order form. That's your goals of care. That's going to tell the EMS and the doctor and the hospital, and when you go into emergency, what kind of care you are. And there's also a tracking record, and that's for your healthcare providers to chart on there the discussions they may have had with you, so that if you go into emerge or you go into see another doctor, they have a record of what's been done prior. So the age-old question is, do we really need to carry around that green sleeve with us? Because everybody thinks that we all are on computers, and we are. The only issue is that they don't talk to each other. So even right now, if you're all familiar with Foothills Hospital, right next to it is Tom Baker. They each have two different computer systems, and they don't talk to each other. So somebody at Foothills cannot look at your chart at Tom Baker and vice versa. We are trying to change that. Right now, there's about 1,600 different programs out there for medical information. It will go down to about 200, hopefully. So it'll get a little bit better, but we're still depending on that paper copy. We're still depending on the green sleeve. And it is really important that if you have a green sleeve, if you have a goal of care, to make sure you take it to your family physician, make sure that you take it to emergency, make sure that you take it to your specialist. Just like my mother, she was in the mall, she had the green sleeve. It would ensure that she got the care that she wanted. She's in long-term care. When I take her out, that green sleeve is in the back of her wheelchair all the time. If I bring her home, that green sleeve is in the back of her wheelchair, just in case. I never know if something might happen. And like this, the kind of answers, do I have to carry this with me everywhere? Well, if you don't, that's okay. It's your choice whether you do or not. If you don't have a green sleeve, that's fine, because everybody's going to be treated as R1 in terms of you're going to get all the care you need. But let's say you're like my mother, you don't have it with you. Unfortunately, if we don't see that goal of care, they're going to treat you as R1, and that may not be what you want, right? So that's why, if it's important to you, carry it with you. If you don't have it, then you may get more care than what you wanted. We don't have a smaller wallet car. And like I said, we don't know your GCDs, because even if it's put in the medical system, they don't talk to each other all the time. Can I use a medical alert bracelet? Remember, I told you it's like a medical order, and it changes. And that's the issue with the medical alert bracelet. It doesn't change. And the goals of care documentation paper should be a living document, that it should be reviewed, and that people should change it as needed. So that's why the medical alert bracelet doesn't really work. Some people have a Capsule of Life. It was a big program. I think the EMS took it out. The Capsule of Life is meant to be information, contact information, emergency information for you. And it was meant to go in your fridge or your freezer. So if something happened, they would know where to look for it. And that was just contact information. The green sleeve is something different. The green sleeve travels with you. It's not left in your home. It makes sure that we know the information, so it goes with you and is changed. And that wasn't the purpose of the Capsule of Life. I'm almost done. I'm just going to show you a short video, and this video is about the green sleeve, how we use it and why. So it's just a 3-minute video, and then we'll just go through some resources, and we'll have some questions after that.
A green sleeve is a plastic pocket, like a medical passport, that holds important advanced care planning documents. It is recognized by all Alberta Health Services healthcare providers, so that in an emergency, medical professionals will have access to your personalized advanced care plan and know your healthcare wishes. You may get a green sleeve from any Alberta Health Services provider, either in hospital or the community. You can ask for one, or your family doctor or nurse may suggest you have one. The green sleeve is your personal property, and you should only have one that contains the most up-to-date documents. The green sleeve holds 3 forms: a copy of your personal directive and 2 Alberta Health Services healthcare forms. A personal directive is a form that you complete. It outlines important healthcare decisions, such as where you might want to live, or what would be most important to you in your life if you weren't able to communicate. Anyone over 18 should have a personal directive. You can complete a personal directive with or without a lawyer, and you can use the blank personal directive form provided in the green sleeve. In the personal directive, you name one or more persons who you trust to make personal and healthcare decisions for you if, in the future, you can't make them for yourself because of illness or injury. The person you choose is called your agent. The Goals of Care designation form is a medical order completed by your doctor or nurse practitioner based on conversations between you and the healthcare team. You do not write on this form. A Goals of Care designation, or GCD as it is referred to, is an actual letter number combination that helps the healthcare team quickly know and interpret your goals of care. Not everyone needs a GCD, or Goals of Care designation. However, it is useful for those individuals when it is important to know and act on their unique healthcare wishes. The tracking record accompanies the GCD form as a written record of your advanced care planning discussions. When all 3 of these forms are put in the green sleeve, this package becomes the one source of truth that reflects your wishes and values for healthcare. At home, place the completed green sleeve on or near the fridge, as this is where health responders are trained to look in a 911 emergency. It is also recommended that you provide a copy of the green sleeve to your designated agent, family, and healthcare provider. It is also a good idea to bring your green sleeve to all health appointments. Remember, the green sleeve is like your medical passport. It holds important legal documents that go with you through the healthcare system. If you don't have a green sleeve, ask your healthcare provider for more information. And if you already have one, keep it current and easy to access in case of an emergency.
So there's some takeaways from today. As I said, don't wait, either in terms of make sure you have those conversations, or writing a personal directive would be really helpful. And remember, you're not meant to memorize the information about the goals of care, but it should prompt you with ideas. It also should prompt you that maybe you do need that discussion with your physician, and that remembering that the green sleeve is your medical passport. So all this information I've talked to you about today can be found on our website, Conversations Matter. So just remember that, and you can get on our website. That's what it looks like. And then you click on the Patient and Families tab. It'll take you to videos. It'll take you to more goals of care information and to our guidebook. Our guidebook is in 7 different languages, and there's more videos on there. So it also takes you to the Speak Up website, which is our national advanced care planning site for all of Canada. So this is what our Conversations Matter guidebook. So basically it has everything that I've talked about this morning. It goes through those 5 steps with advanced care planning. It has information on the personal directive and what to put in it. And it includes the explanations, just like I did today, of those goals of care, so that if you're given a goal of care, you have a reference and you can look at it. And like I said, you can download the booklet. It's available in 7 languages, or you can go on the website under the green sleeves and you can ask for a green sleeve to be sent to you. They'll send four green sleeves per household. And in the green sleeve will be a blank personal directive, will be this booklet and the other documents that you need, so that if you need to have that discussion with your physician, you can take the kit with you to your doctor. Unfortunately, COVID is still with us. If you want more information on COVID, the same website, if you go on Conversations Matter, you can get information about COVID from there also. So that makes it handy. And that's just what it looks like if you want to look at that. We've been talking about kind of really heavy topics today. So I want to kind of leave on a lighter note. It's kind of hard with this topic, but we give it a try. So last night, my sister and I were sitting in the den and I said to her, I never want to live in a vegetative state dependent on some machine and fluids from a bottle to keep me alive. That would be no quality of life at all. If that ever happens, just pull the plug. So she got up, unplugged the computer and threw out my wine. Nasty sister. So in terms of the topic, it all shows you that we do need to have that conversations, because we don't want our wine and our computer unplugged. We want to make sure that our values and wishes, that our family knows them and that they can follow them in an emergency. So now's the time to stop for questions, and Colleen's going to give me some help with that.
Absolutely. We do have several questions coming in. I'm going to put us on gallery here. Great presentation. Thank you very much. Very informative. Very well done. Do you want to close out your screen share there? And
Okay.
we have a few questions here that came in via chat first. Corinne would like to know, can your personal directive state your wishes regarding assisted dying?
It says you can put it in there if you write it on your own. If the legislation changes, then it would be in effect. But right now, we wouldn't be able to follow through on it. But if you go to a lawyer, most lawyers would not, they would refuse to include it on a document that they drew up. But like I said, if you use one of the forms or just handwrite it, you can certainly put it in there. We just can't follow it at this time.
So best to go to the organizations that you referred to there to get that information and maybe have that in your green sleeve as well.
Yeah, like I said, it's an indication of what you might want, but in terms of following through with medical assistance in dying, because you've requested in a personal directive, we can't do that. So that.
Well, if there's no further questions, then Alexander, thank you very much. This was, I agree wholeheartedly. Subi has also said thank you. I agree wholeheartedly that was a very informative presentation, and it did certainly make me think about getting my documentation out here and review where things are and what I should be doing with it. So I think this conversation makes having the conversation with your loved ones a little bit easier. So, people, I think, have a better understanding after today, the importance of having that conversation. Janice has said it's very enlightening. Lenny, well done. Thank you very much.